welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled COVID-19 Science Spotlight. To link to the full program online, please visit the show notes for this episode. I'm delighted to introduce our two expert faculty today. I'll start with Dr. Paul Sachs, who is the Clinical Director of the HIV Program and Division of Infectious Diseases at Brigham and Women's Hospital, as well as Professor of Medicine at Harvard Medical School, both in Boston, Massachusetts. I'm also pleased to introduce Dr. Renslow Sherer, who is Director of the International HIV Training Center, Section of Infectious Diseases and Global Health, and Professor of Medicine, both in the Department of Medicine at the University of Chicago. So let's get started and hear what Dr. Sachs and Sherer have to say about new COVID-19 data and the implications for clinical practice in the future of the pandemic.
Well, hi, Paul. It's nice to talk to you today about an update on COVID information. And I actually wanted to share with you an instance where I found that it was actually a good thing to be wrong. And I'll explain it this way. We did a study here in Chicago where the title of our paper that we wrote for the Journal of Clinical Virology was that people with immune-compromised conditions were not at greater risk of developing severe COVID and hospitalized when they were in the hospital in Chicago. And that was among the first 401 patients that we saw in the hospital in the spring of 2020. And we've subsequently been proven to be actually quite wrong because of larger cohorts. But there was a kernel of truth that I think was important as we published that. And that was some people with immune-compromised conditions actually behave quite similar to others. And in that group, we had 400 patients. There was a mean age of 60, 90% of them were African-American, and 40% had severe illness. The overall mortality was 13%. And of those 400, 130 were immune-compromised. About half had either transplant or HIV or other immune-compromised therapies, and 50% had either current or past cancers. And what we've seen is larger studies from WHO, from South Africa in the HIV sphere that have shown that while some folks with well-controlled HIV, like in the VA cohort in the United States, actually had quite similar outcomes to people without HIV in terms of hospitalization or mortality. Those who have more advanced disease in the WHO study, in the CNIC study, like less than 200 T cells or uncontrolled viremia, clearly have a greater risk of mortality and hospitalization. And so I think one of the current things that is in the news our patients are asking about is the EUA, the expansion of the vaccination for Pfizer and Moderna for a third shot for some people with HIV and with other immune-compromised conditions, in particular for those with advanced or untreated disease. What do you think about that, Paul? Do you agree with that decision?
Well, I feel like the definition of immunocompromised probably lacks precision, and that there's quite a bit of heterogeneity within that population. So some people with that definition are severely immunocompromised, and I'll just cite the people taking B-cell depleting therapies like rituximab as a most important example. And other people in that category, maybe, for example, HIV on treatment with normal CD4, they really don't behave very immunocompromised. And it's probably other factors, comorbidities, that would play more of a role in their poor outcome. So my own feeling is, working at a large academic hospital that has a giant cancer center built into it, Dana-Farber's built in here. Yes, immunocompromised patients are at greater risk of severe COVID. Yes, I do think that they don't respond as well to vaccination, and therefore a third dose is warranted. But as you noted in your paper, there's probably some people who carry this label who aren't very immunocompromised at all. And then you also have mentioned to me in prior discussion that our colleague Joe Iran says that everybody with HIV should get a booster. Well, I hate disagreeing with him because he's so darn smart. But I am going to disagree with him here. I think the healthiest of the healthy people with HIV who've never had severe immunodeficiency and are on ART and suppress viral loads, they would only need a booster if they fall into this latest category as of this week, which is basically people, 65 and older or people under 65 who have intense exposures in the workplace or have some other comorbidity.
Yeah, I think that's very important. The spirit of the recommendation is anyone who has a greater than an average risk of severe illness. So I actually agree also that 50 to 64 age group, expanding that to include those who have significant comorbidities, and that we can be smart in the way that we use the third dose. But this is a recommendation for the Pfizer and the Moderna. What about the J&J vaccine? And I know you've been very outspoken about, first of all, just addressing the question because so many people in our country have received J&J. What do you think should be done? They've just recently promoted some information on the efficacy of a second dose. And it's interesting that J&J, in almost all the studies that have looked at the three different types of vaccines, have said Moderna and Pfizer are either equal, or actually we're seeing Moderna appears to have greater persistence and somewhat higher efficacy in the 94 versus 85%, with something closer to 70% for J&J. And J&J has already been shown to be in the single dose studies to be somewhat less effective in those who are immune compromised, 64% in one study. And with the studies looking at the second shot, there were very small numbers that showed excellent protection against severe and critical COVID, as high as 100%, 75% against symptomatic and severe disease globally. And in the US, that was as high as 94%. And they actually are talking about, should it be 2 months following the initial injection, in which time their antibody titer response was 4 to 6 times higher, or if you wait even longer for a 6-month period between shots, you can see antibody titers rise 9 to 12-fold. So what do you think, first of all, overall in J&J? Maybe you could just briefly say, what did you say in your editorial?
Well, I was contacted by a PhD immunologist at Stanford who said, I needed someone who's clinically oriented because I've heard your opinions about this J&J one-dose vaccine, and I happen to agree with you. And his name was Michael Lin. And we decided to kind of address this issue head on, which is that, first, do we have data that the single-dose J&J vaccine is less effective in clinical practice than the Moderna and Pfizer vaccines? And the answer is yes. And increasingly, we have state data that show that not only are breakthroughs more likely, but actually in some of the states' data, hospitalizations are more likely too. And that's actually quite concerning. And then if you look at the antibody correlates, the one dose has never raised antibody levels as much as the 2-dose approaches have. And even J&J must know that because they are doing this large 2-dose study. And I really think the 1-dose thing was a kind of could we do it with just 1 dose? Wouldn't it be great if just 1 dose were sufficient? Now that they've done the experiment and we're about to see the results, I think we're going to find that it's good, but not good enough. And then the third question, which is perhaps the hardest, is what do we do now that we know that there's a vaccine that's substantially less effective than the other ones that are available here in the United States? And what the official response has been is just wait, we're going to get data soon. And we're seeing a little glimpse of that with this J&J data. And we know that there's an NIH study that's using heterologous boosting. So you're using different boosters after J&J, but we haven't seen those data yet. And we know that the AstraZeneca vaccine boosts tremendously well with an mRNA vaccine afterwards. So is that enough information now to say to our J&J recipients who have been waiting, time to get an mRNA booster? And my opinion is it is enough. The Pfizer vaccine, remember, is FDA approved. It could be recommended by a clinician to a patient who got J&J. The process of shared decision-making is already embedded in our vaccine practices. And you could actually have a conversation with the patient saying, look, you got the J&J vaccine. It's better than nothing, but we can make it more effective with this additional vaccine doses. So that would be my approach as of today. Now, let's see what the data show. You cited the data from that J&J released in their press release. It's not really a paper. It's not really the full data. Once we see that, it may be that getting another J&J vaccine is the way to go. But as of today, I would say it's it's going with an mRNA series. And that is what I tell patients when they ask me.
It certainly makes me nervous to be making these really critical decisions based on press releases or preprints, which it seems like it's one of the two of those. We rarely are looking at approved and completely peer-reviewed papers, which one of the ways that COVID has challenged us all. Absolutely.
Yeah.
I actually have a patient who only would accept the J&J vaccine because it was only one injection. So her vaccine hesitancy only would allow for one dose. And yet she said this is how much maturing there has been. She's grateful to hear of a second opportunity, having read about just the limitations of J&J and the potential benefits for this.
One thing I'm going to mention before you leave the issue of preprints and this is a digression, so it might end up on the cutting room floor. But I will just give you an update on a situation that we experienced at our journal OFID, Open Forum Infectious Diseases, where a very experienced HIV researcher, Andrew Hill, conducted a meta-analysis of ivermectin randomized clinical trials and showed in this meta-analysis that ivermectin had significant clinical benefit. What happened is after he submitted that to our journal and it was peer-reviewed and then accepted for publication, the largest of the studies informing his meta-analysis was found to be fraudulent. And in addition, additional data problems with some of the other studies have come to light. So very wisely, Andrew Hill, with our complete agreement, retracted his submission, and he is redoing the analysis and plans to resubmit it. In addition, he has very generously offered to write a perspective on what it was like to do a meta-analysis where the clinical trials end up subsequently being found to be invalid. I don't know if you know him, but he's a very careful HIV researcher, and I think this took him by surprise. I'm not even getting into the controversies over ivermectin. I'm just talking about what a challenge it is to do good research in a setting where you don't have things peer-reviewed and the preprints just show up.
Certainly, another one of the huge challenges that COVID has presented us with is massive information and the crush of patients and patient care, the difficulties in caring for everybody else and all of the other health issues, and then just both misinformation, active and malicious, and uncertainty about the validity of data that we have without really thoughtful review. It's a tremendous challenge. The other issue that's it raises for me, Paul, is how effective are surrogate markers in thinking about vaccine efficacy and the relationship between, first of all, humoral responses, the antibodies to the spike proteins, or to the RBD, neutralizing antibodies. Is there a sufficient correlation where we should look closely at these levels of antibody titers? Are they meaningful, do you think, in our clinic? And then it always has seemed to me, and this is true for any HIV clinician, that somehow the cellular responses are being undervalued, not measured well enough or in a structured enough format, and not considered as playing a sufficient role. So it's certainly not antibodies alone. But do you think we have good ways with our surrogate markers of evaluating vaccine efficacy?
I don't think they're very precise. You probably know that already. But I do feel like at the extremes, these antibody levels are probably telling us something. And so, for example, there have been so many studies now on looking at antibody responses in immunocompromised hosts of various types that they've been either published or they're in preprint form. And I have to say that the scientist Hilda Bastian has done a great job in summarizing many, many of these studies. So I think if someone gets these vaccines and has undetectable anti-spike antibodies afterwards, that they're probably not responding very well to the vaccine. That's probably an overgeneralization. There might be some cellular response, but compared to an immunocompetent hosts, probably not. And that's one of the rationales behind giving the third dose. I don't think we can tell people, your number's 300, your number is 600, therefore people needed to get another one when their number falls below X, the way we do right now for hepatitis B. We say a cutoff of 10 is considered vaccine protected. So, and then measuring cellular immune responses has always been a much trickier phenomenon, just because the laboratory correlates are much harder to get, and it's also harder for the lab to do. So you can't just measure an antibody. I was chatting with you earlier. We have a lab person here at our hospital who's like, boy, he brought on the COVID antibody tests quickly, and we get the results back like instantaneously. We send the lab, and almost before you even remember you sent it, the result comes back. It takes like less than an hour. So it's amazing. But cellular immune responses, that's going to be a complex laboratory experiment. And I don't think that anyone really has ready access to those assays. I know they're available commercially. Certainly we can't order them in our hospital.
Well, we're going to come back to that in a minute. I'll finish with our study, because there was one other major conclusion that we came to, which is just about the limitation of the definition of severe COVID-19 clinical illness, which is, as you know, all of the Remdesivir studies were based on oxygenation, and we still are gauging use of Remdesivir as to level of O2 requirement. And so severe disease sort of is defined that way. And yet we found that there were 4 people who died in our cohort who actually never qualified as meeting the definition of severe illness. And I saw just this week in JAMA report on the multi-system inflammatory disease in adults, in which half of the patients actually had no O2 requirements, and yet they went on to develop this quite severe clinical illness with end organ damage. And so it just suggests to me that we're missing a lot of the end organ damage in those who don't really have much in the way of respiratory deficiency, but have chronic acute kidney injury or myocarditis or thromboembolic phenomenon. And it just seems we could do better to capture the full extent of morbidity in mortality, but particularly morbidity from COVID-19 with a more expansive definition. And I'm wondering if that over time won't need to include this substantial percentage of people who seem to have prolonged post-COVID syndrome, whether that's 5% or 25%. It certainly is going to be an enormous burden in our health system.
I think it's no secret there are people who have gotten COVID and not have been hospitalized who get insulted when you describe their illness as mild, because they were so miserable when they had it, and symptoms were so prolonged that, it counts as a mild case because they didn't show up in the hospital, or maybe didn't have to go to the emergency room, but boy, I don't think it was mild. This is not an infection people want to get. I think it's one of the great misunderstandings from the early days of the pandemic was that it was a mild disease in most people. It's a pretty crappy disease in pretty much everyone. I mean, I'll take away the asymptomatic cases. We all know people who've had it. And yes, there is a range, but people who get COVID feel pretty crappy.
Boy, you're not kidding. There was also a study just published this week in the Annals that caught my attention that speaks to mortality and the contributors to mortality, and how they analyzed that of all deaths, that 1 in 4 were either aggravated or possibly even directly associated with the presence of a surge, meaning that some of the hospitals simply had either didn't have adequate personnel, they were being triaged not in intensive care units, but in parking lots, or just that all of the crisis standards of care and what the implications are in many states are now fully ramped up in that. Arkansas, Alaska, Idaho, Mississippi. It's really heartbreaking to see the health systems crumbling in that. And I completely believe this study from the Annals. What do you think?
Absolutely. It's a very important study. And I'm not just saying that because that's a former one of our ID fellows is the first author. It tells a story that if you've been in one of these situations, and here in Boston we were, I think in Chicago we were for a while, certainly they were in New York, where you start to sort of push at the limits of what your hospital can do, you can understand how this would happen. And it's one of the primary motivations for our strong vaccine recommendations and even mandates, because keeping people out of the ICU so that you have the capacity to care for everything that happens and not just COVID is so, so critical. I feel very bad right now for all the regions of the country that have this kind of excess ICU use because of COVID, because right now, at least in heavily fully vaccinated. Boston, we're not in that situation.
We're not in Chicago either. And I also knock wood and I'm grateful and certainly would use that as an opportunity to urge people again, please get vaccinated. All right, well, let me take us back to the monoclonal to antibodies and the use of monoclonal antibodies, because one of the things we've struggled with in Chicago is data from the recovery study that suggested, we're not using it as all hospitals aren't. The emergency expanded use authorization actually prevents its use in hospital patients because recovery didn't show any benefit from monoclonal antibodies in that population. Well, further teasing of the data did identify a population where there was a substantial reduction in mortality. That was people who were admitted who had actually no antibodies whatsoever. So you can imagine that if, as in your hospital, you did have very rapid antibody assessment and you saw that someone had no antibodies, the quick administration of monoclonal antibodies could help to reduce their risk of mortality. Is that something that you guys are doing with all the information you've got about antibody formation?
No, I'm going to take us back a little bit to some of the industry-sponsored studies of monoclonal antibodies and just remind people that they didn't work in the hospital for severe illness. And there was even a signal of harm. And so as a result, when the EUA was drawn up, it was really for early treatment to prevent progression of disease, because that's where the data are the strongest. People newly diagnosed who have risk factors for progression, if you get them an infusion of monoclonal antibody, you reduce their risk of being hospitalized by like 70, 80%, which is absolutely sensational. And so that is where we should be really pushing our efforts, is getting it to people as early as possible. But there is a role for their use on the inpatient side. And one of them is, as you alluded to, is this protocol specified analysis of people who were seronegative at the outset of their treatment. They appear to have a survival advantage. And that makes sense from a pathogenesis perspective. But note again that the people who were seropositive, there appeared to be a little signal of harm. So we don't want to just give them to all hospitalized patients. And there's another subset, and I keep mentioning them, these B-cell depleted patients, patients who don't mount antibody response at all. They also potentially could benefit from monoclonal antibodies. And then a final group in the hospital who benefits, and we are doing this, are people who have had nosocomial exposures. And those are typically people who have a roommate who's newly diagnosed with COVID-19 or have a heavy exposure to a healthcare worker with COVID-19. You can give them monoclonal antibodies as prevention, and that's a post-exposure prophylaxis. But other than that, as you note, for hospitalized patients in general, you cannot give monoclonal antibodies because of the EUA. You can get them on an expanded use protocol for a single patient. That's a huge amount of work, but the companies will help you get them, but it's not easy. So I'm looking forward to an updating of the FDA EUA to allow us to give monoclonals to seronegative hospitalized patients with COVID-19, because I think we could significantly benefit them. As for the logistical issues of giving them to outpatients, wow, that's tough. That's tough.
Really hard.
Our system, the capacity to give them, even though we keep ramping it up, does not meet the supply.
And we've seen demand actually substantially rising around the country on the strength of the preventive benefit. Initially, it was very difficult to tell people, you only have a 10% chance of getting severe illness, but we can block that down to 2 or 3% with this infusion. And so the uptake was incredibly slow in Chicago. And now that there's been both more press and more understanding of how serious an infection it is, there's much more acceptability and we are using much more. And even then, the logistics of just the infusion center and all that it implies has been a challenge, but we are seeing quite a substantial rise. And I think cited Mike Cohen's beautiful study in nursing home in a population where there was very powerful preventive benefit with the use of in exposed individuals in a nursing home setting.
I think that the Regeneron post-exposure prophylaxis data, not only did it prevent infection a significant proportion, but those who got infected did better and had a faster viral load decline. So it's a great early treatment. It is logistically challenging. One thing I should mention is that some of the states, because of limitations on who could get monoclonal antibodies because of lack of resources, they're limiting it to people who are unvaccinated, which is a painful, painful thing to hear. Because, of course, the vaccines do not in any way invalidate the utility of monoclonal antibodies. But, of course, the vaccines do make severe illness less likely. So from a medical perspective, you can almost understand a state that doesn't have enough resources to give monoclonal antibodies saying we're only going to give them to unvaccinated people. But what does that kind of do to you ethically, that a person who's chosen not to be vaccinated then gets this limited resource? It really bothers me enormously. Fortunately, we're not in that situation here in Massachusetts.
We're not in that situation either. We haven't taken that decision, and I completely agree. I have a problem with that. I think where it's indicated it should be used. I totally agree with the spirit of it. Well, I want to move on and just pick your brain a little bit about Remdesivir. And
an old friend.
Remdesivir, yes, our dear old friend, because of, really the treatment landscape has been rough, I would say, by comparison, certainly to the vaccination landscape. And yet this was another rough paper for Remdesivir that was just published this week in The Lancet, study out of France that actually found no benefit in patients who were hospitalized. They said they were hospitalized, but actually they reported on a substantial number who were not hospitalized, but hospitalized, symptomatic for more than 7 days and required oxygen support. And I think the key here is we certainly have limited its use, as has been directed by the ACT and other previous studies, to folks requiring oxygen with clear symptomatic disease in hospital. But in this case, it was folks who were symptomatic for more than 7 days. And, just looking all the way down the line at the categories of patients who were either intubated or hospitalized, requiring reflow or any form of supplemental oxygen, there just didn't seem to be much of a difference, and no difference in mortality benefit. And it just reinforces sort of the tension that we've seen in WHO's interpretation and some of the European data as compared to the data in the United States, and points again, in my opinion, to get it done as soon as possible, identify someone at risk, and then treat them quickly and within the first week of symptoms. And I just wondered, has this changed the way that you are thinking about or using Remdesivir in your hospital?
I will tell you that there is a body of evidence supporting the use of Remdesivir that's almost impossible to argue against, and that's a randomized clinical trial that was blinded and very carefully conducted, sponsored by the NIH, that clearly showed that people receiving oxygen who got Remdesivir recovered significantly faster than people who didn't. And it almost was true for people not receiving oxygen. And if you take a look at the stratification, the real predictor of who was going to respond was time from onset of symptoms. And the people who had onset of symptoms early on benefited a whole lot. And the people with onset of symptoms later on didn't benefit much at all. And that includes the worst case scenarios, meaning the people who've been sick for a couple of weeks, who finally struggle to the hospital and get intubated quickly or on mechanical ventilation. I don't think Remdesivir does much of anything at that point. But coming now to support this even more is the outpatient study, which they had completely, I think, almost given up on. But when they actually released the data, it sounds almost as good as the monoclonal antibodies. Now, remember, this is 3 doses of Remdesivir intravenous, so even harder to give than the monoclonals, although it's easier to give Remdesivir than monoclonal antibodies just because you don't need the observation period. And they showed that there was a substantial reduction in the risk of hospitalization in that study. So I'm looking forward to seeing those data in more detail. So the message should be, if you're going to use Remdesivir, start it soon. And our particular practice is that anyone who gets to the hospital with symptomatic COVID, they get started on a Remdesivir right away. If they quickly recover and get discharged, then they don't need to finish 5 days. But that's how we manage it. And we do not typically recommend its use in patients who have already intubated or on ECMO or anything like that. So I'm still, in the supporters of use of Remdesivir in the right context.
We just had one of our residents declined to use it in a patient, and so it generated quite a bit of discussion on the strength of WHO's recommendation and against our own recommendations. And it led, and this paper was the one that was cited. So there was quite a discussion. The patient did end up actually getting Remdesivir, and I completely agree. We have continued with its use, and the earlier, the better, I think, just as the same with Tamiflu or oseltamivir, antivirals, you don't have much of a window for efficacy.
No, you don't.
The sooner that it can be done, the better. So that leads, let's stay on treatment. And this is just another of her clinical thoughts more recently on this intriguing drug, fluvoxamine, that is an old warehoused antidepressant that has some anti-inflammatory activity that's been proposed as a treatment for mild to moderate illness, for something we really don't have anything unless the Remdesivir data holds. And it's an oral form. I think it was 200 milligrams twice a day for 10 days. So it seemed to reduce the risk of hospitalization in that population by 29%. So the data, it didn't have long-term other consequences. So all of the other endpoints like viral clearance or overall mortality or days of hospitalization didn't change, but it did substantially reduce the likelihood of hospitalization. And I thought you gave it quite a positive spin. So I'm interested if you just why do you think that this we should look at more closely? Why won't our hopes be broken as they were with?
Yeah. I mean, I think
hydroxychloroquine.
So, repurposing drugs, it's a long shot. There's really very little chance. Your prior probability of success with this is slim, and we've seen that now with hydroxychloroquine. We're going to see it with ivermectin almost certainly, or if it works just a little. Whether it's zinc, azithromycin, doxycycline, vitamin D, the list is long and it's depressing. But this one stood out for a couple of reasons. One, the mechanism is probably more related to an anti-inflammatory property that is an off-target effect of SSRIs in general, and this one in particular. There's observational data that people getting SSRIs are less likely to have severe disease, but who knows what that means? It's observational data. Then there was a really nicely done small randomized double-blind trial published in JAMA that showed a really quite striking effect. It was so striking, in fact, that there's a couple of people who think, why isn't this standard of care already? But as you know from small clinical trials, all it takes is like a few patients to change categories, and you end up with no significance at all. So the statisticians term those results very fragile. And then a very widely publicized outbreak occurred in a California racetrack where people with COVID were offered the chance to get fluvoxamine, and some of them chose to take it. The sicker ones and the less sick ones chose not to take it. And even though the sicker ones chose to take it, they actually did better than the less sick ones. So all of these data then went into this well-done trial, which is called the Together trial, which is being done by good Canadian and Brazilian researchers. And they they presented their data at an NIH conference, and it's now available for full review. They think there's a 95% approximate chance that this is actually a real finding. Their Bayesian chance, based on these data, it's going to do something. I don't know that this reaches the level of guidelines because the effect is not huge, but it's almost certainly doing something rather than nothing. And the good news is that there's two other large double-blind studies going on that are looking at fluvoxamine. And I would say of all of the repurposed drugs, this and inhaled corticosteroids probably are the ones that are highest on the list to succeed. I'm sure you heard that, budesonide is already shown in an open label trial that it prevents disease progression. And then ciclesonide, which is another inhaled corticosteroid, looks like it had a pretty big effect on clinical outcomes, although the primary outcome wasn't met. So I'm putting those towards the top of the list until molnupiravir data get released, because we don't have anything right now. It's really pretty frustrating for clinicians. Someone gets diagnosed in the outpatient setting, and unless they meet criteria for monoclonal antibodies, and unless they can get monoclonal antibodies, we don't really have anything to offer them. And, I'll give you an anecdote. I was contacted about a 21-year-old who got diagnosed with COVID, who has no risks for disease progression. And the question from the concerned parent was, can they get monoclonal antibodies? Well, even though they've expanded the criteria for who's eligible for monoclonal antibodies, it does not include completely healthy 21-year-olds. So the answer was no. And there really is nothing right now. So this would be perfect for that subset of population in whom a very low risk intervention that's not expensive might keep them from progressing and getting sick. And who knows, might eventually prevent long-term complications.
Yeah, you invoked earlier the notion that there might be one antiviral pill and fluvoxamine and an inhaled steroid and see you later. And that might be, for the folks with mild to moderate illness, it might be all that COVID turns into. Isn't that a beautiful vision for the future?
God.
It's too good to even imagine.
Well, speaking of beautiful visions, I believe you have some modeling visions to share with us.
Well, I do. And there are two of them that are sort of circulating out there that have completely different views of the future. The one I think that got us started earlier out of the University of Washington, the Institute for Health Metrics and Evaluation, has painted a fairly grim picture for the next 6 months, saying the pace of the epidemic is likely to stay the same because of the large number of unvaccinated people that remain in our country, and that we're probably going to see the same sort of level of new infections, and another 100,000 Americans will die, which is really unthinkable given where we've already come to. And yet a contrasting group, the COVID Scenario Modeling Hub, using different sources of information from medical centers, universities, has come to a very different conclusion. And the very important premises that they are basing this on, first, is that vaccines are indeed approved for children, which certainly look promising for age 5 to 11, and that there will be rapid uptake in that group, which again, I think is plausible, but will it get past 60, 70, 80% is hard to know. But if that is true, and if there's not a new variant that is even worse than Delta, which is so bad, and we've already seen Delta beating back Mu and the other variants quite effectively. So there's a real question out there in the literature: is Delta the worst that COVID can throw at us, or is there other variants that are still worse to come? But if those conditions are met, they believe that we're starting a decline now that will result in something less than 10,000 cases today across the United States by March of 2022, which is such an optimistic view that it's almost, again, too much to hope for. And I wonder if you have your own feelings about which of these is likely to be true.
Well, I'm thrilled to see an optimistic model, but I will believe it when I see it. Because remember, we all thought this summer would be just sensational because case numbers had dropped through March, April, May, June, and then all of a sudden, then we're in this Delta mess. So I hope this is true. I mean, at some point, the combination of vaccine-induced immunity and prior infection-induced immunity should make a dent on these surges. And I think, as I alluded to already, this surge here in Massachusetts is way easier to deal with than the previous two we've had. So perhaps over time, each subsequent iteration of this is going to get progressively smaller. Kind of think about like if you throw a bouncy ball and see it bounce, each bounce gets smaller. That's kind of the way I think that COVID surges are going to happen over time. And I hope they stop bouncing entirely.
Well, apparently our friend David Wall in North Carolina is musing over whether this particular Delta epidemic is a dromedary or a camel. You may know that a dromedary has a single hump. That's what you're hoping. And he's as he is, and not a camel with a second hump that's even worse than what we've seen before.
No, I'm talking about progressively smaller humps.
Yes, exactly. And I hope that that's the case. I think we're near the end of our time, Paul. I wonder if there's any other things that are on your mind in closing. I I suppose I'm eager for our colleagues to appreciate what I think is true, that we've now had demonstration of multiple vaccines with efficacy and safety in pregnant women, and that's a tremendously important advance, and that there's been slow uptake. There's way too many pregnant women who are unvaccinated out of our early hesitation. So I hope that word is out there. And I mentioned already safety and efficacy in children age 5 to 11, which looks really very strong. I do expect FDA approval in the very near future. Anything else that you'd like to mention?
Well, maybe I'll bring up molnupiravir again. This is an antiviral we've heard little whispers that data are promising for a while now, that it works in outpatient disease to prevent the progression. And, just a reminder, this is an antiviral that there are some safety concerns about, but I don't know whether those safety concerns would apply for a short course that you would give for a respiratory viral infection. But, let's see the data. I am cautiously optimistic that these little hints that we're getting are that it works. As you probably know, that they've also tried it in India, where they had access to a generic formulation. So fingers crossed. There aren't a whole lot of other antivirals given orally that are that far along in development. The ACDG is doing some studies of oral antivirals that have a different mechanism of action, including a protease inhibitor. So we'll see.
Well, absolutely. It's I'll leave with that optimistic thought. The idea that we have an oral antiviral and maybe an oral anti-inflammatory for people with mild to moderate disease, and we keep making progress with vaccinations. So having just a very good thought for the outcomes that we've described. And it's always fun to talk to you, Paul. Really enjoyed our conversation.
Same with you, Renslow. Take care.
Thank you so very much to Dr. Sachs and Sherer for that engaging discussion, and thanks to our listeners for joining in. As a reminder, to view the full educational program online, COVID-19 Science Spotlight, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.